You had performed cataract surgery was performed with a patient who had an ICL in,
Yes.
right? So what formula did you use to calculate the IOL power in this case?
The same. I don't make any. You mean in terms of taking into account that the ICL is there?
Yeah.
I mean, I think we used the Barrett in him, and I used my usual strategy.
So my only concern with that is that the AC depth is artificially shallow.
But it's not. It hasn't been an issue.
Because what I typically do is I typically either try to measure with OCT what the endothelium to anterior crystalline lens distance is.
That would be the, yeah.
Because you do lose about a millimeter or so, right? So again, a shallower AC, the formulas may potentially knock off a bit of the power. They may, right? Especially the ones that take into account AC depth.
Okay.
So that's one question. And of course, there's also some refraction of light through there, but that's minimal though. The refraction of light through an ICL is minimal. So I think there's probably more work. I looked up some of the studies on this one.
Okay.
And so that's why I typically go back to using two variable formulas with those.
And so would you, like in this case, IOL Master 700 seems more advanced, but it's OCT based. You think it's actually detrimental instead of using just a purely optical?
It depends what you enter for your AC depth,
yeah.
I think. I think you have to be careful. If your AC depth is 3.3 millimeters or so, that's actually an artificial AC depth. And the formula is based on what they expect crystalline lens AC depth to be. That's just a small
And that's
thought.
but that's a good point, because it may be that having more sophisticated equipment may not be necessarily, in some cases may not necessarily be better, because it does take into account that other factor and would explain part of the hyperopic result.
So I'm just going to say one point that I think is very important. I think the sophisticated equipment has been wonderful in bringing us so much technology and stuff like that. But I don't want people to feel bad if they don't have all this sophisticated equipment and don't feel like they can't take care of their patients properly. I think more of an important point, because the IOL Master 700 is significantly better and the lens star than the IOL Master 500, but the IOL Master 500 is still good. It's still a good technology, and manual Ks are still good technologies, and Atlas topography is still a good topographer. All of these other ones, the eye trace, and if we have all the toys, they're great to have, but that doesn't mean you still can't do a good surgery as long as you use multiple technologies. I think that's the point that we want to make. To have all the toys are great, but we're living in the reality of reimbursement, and reimbursement is very low, and it's hard to buy all these new technologies for every single practice in this country, right? So we have to look at reality, and I think the point I would make is that I would just make sure we have more than one technology, but we don't have to have every single amazing technology that's out there, because the reality is you don't need them all the time.
Yeah,
right?
I think that's very well said. And I think the other important thing is just a patient discussion, right? I mean, the expectations are very high, and we have to tell patients that there's a certain percent of patients that we may not hit the target, even with advanced technology in my hands even, right? So I think that's important. I think Guillermo's case really highlighted again, despite all the technology, the history was the most important technology you had. So getting the history of what happened in this scandalous murder is more important than actually perhaps getting someone's fingerprint, right? You know, because you got a history saying that this was an issue from prior to even having the ICL procedure done. So sometimes we lose that touch when we have all this technology. We kind of just plug everything in there. We forget the history of it, and that comes back to bite us. So it always comes back to history, and it also comes back to, again, reaffirmation of testing, as we've heard.
And I think another point is the discussion. I mean, that comes up in the toric lens calculations, but also like you always have to anticipate that there could be adjustments needed. And in this case, it was that. He was a great patient to work with, and he knew exactly what to expect. He was really happy, even though I could see, really, you're happy? But you know, he was always willing to work with me in all of those until we got to the final point of putting the contact lens, removing his other lens aberrations, and clearing up his vision with cataract removal as well.
Excellent. So before we go to the audience, we've got a couple of minutes. Agent Rai, Agent Mastercard, any last ditch options? You guys are the new members of the team. You're the future of the CSI team here.
Department.
I mean, it's a pleasure to be here. Just to reiterate a couple of things. The one thing with the temporal disc photopsis we were talking about earlier is I found what's worked really well is to acknowledge the phenomenon for patients. And that way they know they're not crazy, you're not seeing anything, and that everything is as expected. And because I've had a couple of patients like this, and once they're reassured that I know what they have, they feel a lot better, and they're happy to wait it out.
And having a great discussion with your patient pre-operative, before the operation is such a good thing to do every time and to spend time with your patient, and it can save you from many things.
Great. Any last thoughts from the group here? I think that's Jit.
I have
So
done
the,
that.
the question
Yes.
is toric lens in a keratoconus patients had cross-linking.
I have done that. It's really, really in well-selected cases. Usually, I have found that pellucid cases seem to fare better, also in terms of IOL calculation and the axis. It's very, very selected cases, very, very conservative, even more than my approach yesterday.
Yeah.
But and I always like that everything should match. You know, if the Ks from the biometry match with the topography, match with the total corneal refractive power from the Scheimpflug imaging, like Pentacam. If everything matches, it's not excessive. I have done it, and it's been okay. I wouldn't say great, but it's been okay. It's doable. And I think it works better in pellucid compared to keratoconus itself.
I think there's two big points, though, I think they're really important. Is that patient going to be wearing RGP contacts after?
That's a good point.
If they're going to be wearing RGP contacts after, then absolutely not, right? And that's important to get that history. Second thing is, and I know if the cataract's dense, it's hard to know, but do the glasses help with cylinder? Someone has, 2 diopter cylinder at 80 degrees, and the patient has an improvement in their best corrected vision with those glasses on versus without, or just measuring sphere only. And if their glasses actually help, then that gives me some indication, and again, the glasses, they match up to the K axis as well. That's important. I look at that importantly as well, because I think that tells you that, correcting their astigmatism will help this patient who has some irregular cylinder. So that's an important point. It's hard to know if the cataract is dense, of course, but that can be also gleaned by history as well. So those are 2 important points with toric lenses in these patients who have these, keratoconus or pellucid degeneration.
And so in this particular case, as good as the patient was and as great discussions that we had, I didn't even think about putting a toric lens. So I put it purely monofocal.
Okay, great. Well, like any team, we got to finish on time. And I want to, again, congratulate this wonderful team I got to work with here to solve these very tricky problems. I mean, they went through this amazingly well and worked together as a team. Most of the team was working well together. But all in good fun. All in good fun.
That was part of the shtick.
I know, exactly. Well done. These guys are great actors. Got a big future for TV
It's
here.
just show business.
And thank you all for coming 6:30 in the morning and participating in this session. Enjoy the rest of the meeting. We'll see you around again. Thank you.
Thank you very much.
Nice job. Thank you.